Preterm labor is the leading cause of infant morbidity and mortality globally. Very rarely, doctors like Archana Verma, in spite of being born at 30 weeks, they make it so well in life. But others may not be as fortunate. That's why the pathogenic processes leading to preterm birth are major targets of obstetric research. Preterm birth may be spontaneous or indicated or iatrogenic, what we say, because of concerns about maternal and fetal status. Today, I'll be restricting myself to spontaneous preterm birth. There are 4 major pathogenic processes in the initiation of preterm labor. Number 1, premature activation of the fetal hypothalamic pituitary adrenal axis in response to maternal and or fetal stress. We all know this has to be activated at term due to the changes that happen in the hormonal milieu as well as other things in the lady as well as fetus. But if there is premature activation, a preterm labor will be the result. I am not going to talk about this at all. Second, exaggerated inflammatory response or infection. I am going to concentrate on this mainly. And or an altered genital tract microbiome. This is a very important issue in every aspect, whether it is the genital infections, cancers, and even the neonates that are born out of cesarean delivery or vaginal delivery. It has become a very, very important issue. Number 3 is decidual hemorrhage. Typically, it's because of placental abruption. And number 4 is pathologic uterine distension. The uterus always distends, but pathologic distension, like let's say multiple gestation or maybe abruption, and that's why there is increase in the uterine size, or a big baby due to hydramnios. So this will again lead to preterm labor. But as I said, I will restrict myself to exaggerated inflammatory response or infection and or an altered genital tract microbiome. Infection-induced fetal stress. This is a very important word. Infection-induced fetal stress. Fetal cortisol to DHEA ratio remains low, and there is no direct correlation between fetal adrenal gland volume and either cortisol or DHEA levels. This suggests that infection-mediated spontaneous preterm birth may act via a different pathway than the premature activation of hypothalamo-pituitary adrenal axis. This has to be clarified right in the beginning. So that's a different pathway, and infection is a different pathway. That's why I have put it right in the beginning of the slide on infection-related topic. Preterm labor and infection or altered microbiome is a very, very important issue, as I said earlier. Epidemiologic studies using lab and clinical data show an association between spontaneous preterm birth and the presence of systemic and genitourinary tract pathogens. So it could be the pathogens in and around, or it could be from a systemic pathogenesis, as well as an altered microbiome. It need not be a pathogen as such. An altered microbiome also can give rise to preterm labor. We will examine that in the subsequent slides. First of all, preterm labor and asymptomatic bacteriuria. Most of us do not bother about asymptomatic bacteriuria That is because the patient herself is not bothered, because as the name suggests, she is asymptomatic, but she is carrying colonies of bacteria, sometimes very pathologic, and that can give rise to preterm labor. So many preterm labors are actually a result of this, because neither the patient nor the doctor is alerted. A retrospective study of nearly 2 lakh deliveries showed that 2.5% of patients had asymptomatic bacteriuria. That's quite high actually, which was independently associated with spontaneous preterm birth. That means that alone, without any other confounding or comorbidities. The adjusted odds ratio is 1.6, which is quite high. Conversely, the diagnosis and treatment of asymptomatic bacteriuria appears to reduce the risk of spontaneous preterm birth. It's something like proof of pudding is in eating. So first you have said that, yes, there is a direct relationship between asymptomatic bacteriuria and preterm labor. And how do you prove that? By treating asymptomatic bacteriuria by appropriate antibiotics, you can reduce the spontaneous preterm birth. So this has to be kept in mind. That is why many centers now are doing the urine culture routinely in the first or second trimester. And in Manipal, we do that. In fact, later in my talk, I'm going to highlight that particular point. And this is a Cochrane review, which has clearly come out with this recommendation. Now I turn my attention towards preterm labor and chorioamnionitis. Recently, day before yesterday, I took this class for my postgraduates. The new terminology for chorioamnionitis is III, that is intrauterine infection or inflammation. Because it is not just the chorion and amnion are involved in the infection, it could be amniotic fluid, it could be fetus, it could be even the placenta. So all of them will have a role in the initiation of preterm labor. So it's called III. Both clinical and subclinical chorioamnionitis. I'm going to explain to you what is clinical and subclinical in just 3 slides. Are much more common in preterm than in term deliveries. Because if there is chorioamnionitis at term, if she gets into labor, anyway, we can deliver her and we can get rid of chorioamnionitis, because one of the important management protocols in chorioamnionitis is delivery, apart from giving antibiotics. So it is only in the preterm situation we are worried about chorioamnionitis, both in terms of diagnosis as well as in the management of it. And it may account for 50% of spontaneous preterm birth before 30 weeks of gestation. This is an alarming figure. So there may be a chorioamnionitis subclinical sometimes, or the most of the times, and obvious sometimes. So we have to keep this in mind. That's why I'm going to show next 3 slides how to actually diagnose III. The diagnostic criteria of III, there are terminologies and features. The first terminology is isolated maternal fever, or it can also be called documented fever. Now, what is this? Maternal oral temperature equal to or more than 39 degrees centigrade or 102.2 Fahrenheit on any one occasion is good enough to call it isolated maternal fever or documented fever. Or if the temperature is lesser than this, a repeat value remains at least 38 degrees centigrade or 100.4. So if it is 100.4, it has to be on the repeated times, whereas if it is one time 100.2, it is called documented fever. The suspected III, you can also consider this as sometimes subclinical, is fever without a clear source of infection plus any of the following: that is baseline fetal tachycardia, that is more than 160 beats per minute for more than 10 minutes, excluding accelerations, decelerations, and periods of marked variability. So even a basal tachycardia. And then maternal WBC count more than 15,000 per cubic millimeter. We all know there is some amount of increased WBC during pregnancy, but if it is more than 50,000, it is alarming. Definite purulent fluid from the cervical os is a case of suspected triple I. Now, what is confirmed triple I? In addition to what I said earlier, that is fetal tachycardia, maternal increased WBC, and a frank pulse, there should be objective lab findings of infections such as positive amniotic fluid gram staining for bacteria. So you can yourself check if there is PPROM, take the amniotic fluid under the microscope and look for gram staining of the bacteria. Low amniotic fluid glucose, that is less than 14 milligrams per dl. High amniotic fluid WBC. I'm not talking about maternal WBC. I'm talking about amniotic fluid WBC count in the absence of bloody tap, that is more than 30 cells per cubic millimeter. A positive amniotic fluid culture, this is the gold standard actually, or histologic evidence. This usually we do after the delivery. We can send the chorion or the membranes for histopathological evidence of infection or inflammation or both in the placenta, fetal membranes, or umbilical cord vessels. But sometimes you may not remember all the criteria, or you may not have all the things in a given lady. So ACOG suggests that patients with isolated fever of more than 39 degrees centigrade without another clear source should be managed as having suspected intra-amniotic infection or triple I, as they are at high risk for an adverse clinical outcome, especially preterm labor and all the other things. Even National Institute of Child Health and Human Development criteria de-emphasized use of maternal tachycardia and fundal tenderness for clinical diagnosis. Just a fever is good enough. Now I come back to preterm labor and other bacterial infections. Lactobacillus. Lactobacillus, as we all know, is the predominant flora of microbial community in normal pregnancy and even normal ladies. The prevalence of a lactobacillus poor vaginal community, state type 4, that is CST4, what we call, is inversely correlated with the gestational age at delivery. That means the more the prevalence, the earlier the baby will deliver. The risk of spontaneous preterm birth is more pronounced for women with CST4 plus elevated Gardnerella or ureaplasma. So as it is, the lactobacillus is less, and then there is an added infection of Gardnerella or ureaplasma. This makes it more risky. However, treatment of bacterial vaginosis does not reduce the spontaneous preterm rates in low-risk patients. This is one of the observations. Now let us look at preterm labor and other bacterial taxonomies. A nested case control study of cervicovaginal microbiota among 107 patients with spontaneous preterm birth and 432 women with term deliveries found that Mobilincus curtisii or Mullerius to be the only bacterial taxa significantly associated with increased risk of spontaneous preterm birth among all participants. However, they also saw among African American women 5 separate taxa were significantly associated with this. But the ones which I already mentioned, that is Mobilincus curtisii and maybe other Maggie Bacillus Indolicus, had the strongest association with spontaneous preterm birth with rates over 60% and 55% respectively at their highest relative abundance. This association disappeared among patients with these taxa, but also had abundant lactobacillus, again re-emphasizing this healthy lactobacillus is a must. The colony should be good in the prevention of bacterial vaginosis and thus prevention of preterm labor. Among newer technologies have now come to diagnose infection, because many a times when we send for culture, we get a negative culture and we just keep quiet. But she promptly gets into preterm labor. So how to diagnose such infections? So the newer technologies like metagenomic techniques, don't ask me what they do in this, including surveillance of the 16S RNA gene. Probably if you can't culture or grow the bacteria, at least if you have the evidence in terms of their RNA by the genomic techniques, then also they have found that there's an increased understanding of the spectrum of cultivated and uncultivated human microbial agents. So these technologies have given us an insight into this, which is not seen in the culture, which are involved but in the pathogenesis of preterm labor. So these techniques, using these techniques, several groups of investigators reported that in preterm birth, secondary to infection, approximately 2/3 of the amniotic fluid bacteria detected by culture-dependent methods were not isolated in the culture. So that is the importance of these newer techniques. So if you ordinarily send for an ordinary culture, you may not find any growth. But these techniques will tell you that, yes, it is infected situation. And these are the different bacteria that they could isolate by these metagenomic techniques. Then there is Integrative Human Microbiome Project, which told us through 12,000 samples from 45 preterm and 90 term birth controls, longitudinal analysis of metagenomic, metatranscriptomic, cytokine profiles, and 16S RNA identified lower vaginal levels of lactobacillus and higher levels of bacterial vaginosis associated bacterium 1 and other groups in the patients having spontaneous preterm birth. So that means this technique is very important now. We should adopt these techniques. Of course, maybe it is not available everywhere. I have not heard of this being used in Manipal also. The risk of spontaneous preterm birth with selected infections. We can see here bacterial vaginosis before 16 weeks, the odds ratio is 7.55. It's very high. Neisseria gonorrhea is 5.31. Asymptomatic bacteriuria, as I said earlier, 2.08. Chlamydia, 2.2 before at 24 weeks, and at 28 weeks, 0.95. And Trichomona vaginalis, 1.3, and Ureaplasma ureolyticum, 1. So let us look at why infection should cause preterm labor. Pathophysiology. There is bacterial degradation of membranes. Pseudomonas, Staphylococcus, Streptococcus, bacteroids, and Enterobacter produce proteases, collagenases, and elastases. These are the enzymes that can degrade the fetal membranes and lead to preterm pre-labor rupture of membranes, and with subsequent spontaneous or indicated preterm birth. So when there is PPROM, we sometimes ourselves want to deliver the baby. Otherwise, also they will get into preterm labor. Then there's a direct uterotonic effect of the bacteria also, other than degrading the membranes. And what is that? Bacteria will produce phospholipase A2, which leads to the production of prostaglandin, and they also produce endotoxin. These substances that stimulate uterine contractions and cause preterm labor. So bacteria will act two ways. One is they will degrade the membranes, through all those protease enzymes. And secondly, they also stimulate the synthesis of prostaglandins and endotoxins, which are stimulating the uterine contractions. Then there is bacterial induction of inflammatory response. After degrading the membranes and directly causing the uterine contractions, they will excite an inflammatory response, leading to uterotonic effects. Let us look at that. Bacterial ligands bind to toll-like receptors, TLR-S, what we call, expressed on decidual, amnion, chorion, cervical, placental, and local leukocyte cell membranes. This induces the transcription of NF-kappa B, which then triggers a maternal and or fetal inflammatory response in susceptible individuals. And these responses are linked to preterm birth. See how beautifully they go and attack every possible levels and excite inflammatory responses. TLR-mediated response characterized by the presence of activated neutrophils and macrophages, various pro-inflammatory mediators like interleukins, tumor necrosis factor, granulocyte colony stimulating factor, and matrix metalloproteinases. These are different mediators. They will somehow increase the prostaglandins and they will weaken the membranes like a double-pronged attack, PPROM, uterine contraction, and then preterm labor. I'm going to show remember all these names. I'm going to use that in the final algorithm. Key initial mediators of this response are interleukin-1 beta and TNF. They enhance prostaglandin production, as I already said, by inducing COX-2 expression in the amnion and decidua. And also, to complement this, they inhibit prostaglandin metabolizing enzyme 15-PGDH in the chorion. So net effect, increase in prostaglandins. Moreover, interleukin-1 beta and or TNF directly enhance the expression of various MMPs in the amnion, chorion, decidua, and cervix to degrade the extracellular matrix of the fetal membranes and cervix. So don't worry, it is nothing great. Basically, whether it is bacteria or inflammatory response, they have to work through either weakening the membranes so as to give rise to rupture of membranes and increase the production of prostaglandins. But there are so many mediators they use, and that's how they will finally bring in preterm labor. Now, immunohistochemistry has given us more insight into the hormonal things. Immunohistochemistry is staining of placentas with chorioamnionitis associated preterm birth show significantly lower progesterone levels in decidual cells. Now, we all know at term what happens is there is an altered ratio of progesterone and estrogen in favor of estrogen. Progesterone goes down and estrogen goes up so that the oxytocin receptors are increased in the uterus and they will respond nicely to the prostaglandins and other toxins, cytokines. So that's how we have also understood that there is decreased progesterone level whenever there is infection, chorioamnionitis. The treatment of cultured term decidual cells with interleukin-1 beta decreased progesterone expression. This is a double proof. So when you treat the cells without infection, also when you treat these decidual cells with interleukin beta 1, this is a wonderful study that they are doing, the groundbreaking study, and they have proved that this will decrease the progesterone as well as progesterone mRNA levels via all those kinase signaling. This reduction in progesterone expression may account for studies showing no benefit of progesterone supplementation. This is a very important particular sentence I want all of us to understand is that See, sometimes we simply give progesterone. Whenever a patient comes with preterm labor, the standard thing, even in Manipal, what we do, we first give one injection, progesterone caproate. And then we sometimes start on micronized progesterone and everything. Because so many companies, so many representatives are coming and telling us that give progesterone, give progesterone, give progesterone, it will relax the uterus. But in the presence of infection, there is so much lowering of the progesterone, and there is also expression of the progesterone. No amount of progesterone is going to help. So that is what we have to understand. So there is elevated pro-inflammatory mediators. These have been demonstrated in the amniotic fluid of women with preterm labor with intact membranes also. See, the standard recommendation by everybody is that if the membranes are intact, don't start antibiotics. Only if there is PPRM, you start antibiotics. I have also taught that. But today, I'm telling something different after totally understanding this. There can be an infection even with the intact membranes, and that has to be tackled. These levels correlated well with the positive results from culture of the amniotic fluid and fetal membranes. So when you do that, even with the intact membranes. So elevated pro-inflammatory mediators, a review of 17 studies with so many women, elevated cervicovaginal and amniotic fluid interleukin 6 levels at mid-gestation predicted preterm labor. So patients with intraamniotic inflammation destined to deliver preterm appear to present unique amniotic fluid vaginal cervical secretions and serum proteomic profiles. So this again proves that the inflammatory response is the one which is responsible for preterm labor. There was a very interesting thesis that one of our students did in Manipal, periodontal disease and preterm labor. 2 systematic reviews have reported an association between periodontal disease and adverse pregnancy outcome, such as preterm labor, but did not provide conclusive evidence that pregnancy complications, including preterm birth, result from periodontal disease. That means they found an association, but they could not prove that whether it was a cause itself. Causal relationship was not established. Oral bacteria that have been associated with both periodontal disease and preterm birth include all those things. I can't even pronounce them, so I'm not going to pronounce them. There are theories. The periodontal flora may be seeding the fetoplacental unit and cause local inflammation. So you have to have a proper dental hygiene. Inflammatory mediators of periodontal origin may cause systemic inflammation. They may not seed to the placenta or the membranes, but a systemic inflammatory response is also bad enough to cause preterm labor. That's what we have understood. Periodontal disease is a marker of individual who have a genetic predisposition towards exaggerated local or systemic inflammatory response to a given stimulus. That means, let's say a person gets often periodontal diseases. When she becomes pregnant, we have to be very careful because she has got a sort of genetic predisposition towards an exaggerated local or systemic inflammatory response. So during pregnancy, if she gets any infection, not necessarily dental infection, she always will have an exaggerated local and systemic inflammatory response. And because of that, she will get into preterm labor. So this is again proving that there is some connection, but we don't know whether it is really causal effect. So now I come to my algorithm, which I promised. Having understood all these things, to put it in a nutshell, I told you there are 4 main mechanisms. Number 1 is the pituitary adrenal connection of the fetus. Second one is the infection, chorioamnionitis. Third one is the decidual separation. And the final one is the distended uterus. Now let us see step by step how the infection, or I am putting it here as chorioamnionitis, will cause preterm birth. First of all, there will be increased interleukin 1 beta, and this will bind to all the receptors. There will be NF-kappa B, you have heard this word before, that will increase COX-2 activity, which in turn increases prostaglandin F2 alpha. There is also ERK1 or 2 MAP kinase, which will decrease the progesterone levels. Even this prostaglandin 2 alpha will also decrease the progesterone levels. As a result, there is decreased progesterone activity. And as you can see, the net effect is increased prostaglandins and increased metalloproteases. So I told you, ultimately, please remember only two things. Number one is the membranes have to be weakened and prostaglandins have to be secreted. That is the perfect recipe for, as you can see here, membrane rupture, cervical ripening, increased contractions, and preterm birth. So this is in a very simple way. Forget about all this NKF and all those things. Basically, what infection does is it will weaken the membranes. It will increase the prostaglandin production through different mechanisms, and that's how preterm labor will set in. Now let us look at the stress and or increased HPA axis. There is increased glucocorticoid receptor activity. As a result, these things will happen. And finally, they also have to work through this way only. There is decreased progesterone activity and rest of things. If you take the other route also, abruption, there is increased prothrombin binding PARs, and that also will increase COX-2. There is decreased progesterone levels and decreased progesterone activity, increased PGF2 alpha, increased MMP3, membranes rupture, cervical ripening happens, increased contraction leading to preterm birth. Even the distended uterus abnormally pathological distension also will work this way. They separate the membranes, there is prostaglandin secretion. So what are the interventions? This is the last part of my talk. I'll take another 5 minutes. Having told all these things, if I don't tell you how to do the interventions, it's of no use. Urine culture, as I told you, should be a practice. If we are not practicing all this while, it has been told in 1995 and 1999, but we didn't bother last 20 years. From today, let us make a routine culture at least one time in pregnancy, especially in the, at least maybe at the end of first trimester or beginning of second trimester, on all pregnant women. So this should be a habit, because we have seen that asymptomatic bacteriuria can give rise to preterm labor. You may spend lakhs of rupees in NICU. Just one urine culture will not cost anything. So let us do this. And regular antenatal screening is recommended for women at high risk for asymptomatic bacteriuria. First sentence says for every woman, at least one culture. But the second bullet point says regular screening for women with sickle cell trait, recurrent UTI, diabetes, and underlying renal disease. Very often we have to do cultures and treat it. Women with asymptomatic bacteriuria should be treated with antibiotics to reduce their risk of developing pyelonephritis and preterm birth. They may refuse the treatment because they say, I don't have any symptoms. But if there is colony, you have to treat it. The next one, genital tract infection and colonization. Some trials reported reduction in spontaneous preterm birth with routine screening and treatment of infection in early second trimester. But nobody does routine screening for genital infection. Only if the patient comes with vaginal discharge or if there is any other symptoms, may we do this. Even then, we don't send for cultures as a routine unless she has got frank pus or PROM, while others have not reported any benefit. So discordant findings may be due to confounding by recolonization or reinfection after therapy, intercurrent use of non-protocol antibiotics. You are simply giving some antibiotics or half-hearted antibiotics. Failure to culture fastidious bacteria, leading to misclassification of women as non-infected. So sometimes, as I told you, there may not be any growth in the culture. So we may have to resort to genomics. That may become a routine in future. You will realize that there is infection which requires treatment. Role of empiric antibiotic therapy. Empiric antibiotic therapy does not reduce preterm birth. A meta-analysis showed us that there was no significant association between antibiotic treatment and reduction of preterm birth, regardless of criteria used to assess risk, antimicrobial drug administered, or gestational age at the time of treatment. So best is to do a culture sensitivity and look at the sensitivity and give the appropriate antibiotic instead of just throwing antibiotic as a routine. Even Cochrane data meta-analysis showed that intervention did not significantly reduce the risk of preterm birth or PPROM. So blindly giving antibiotic, misuse of antibiotics is not accepted. Bacterial vaginosis and ureaplasma and GBS. Prospective control studies and meta-analysis have reported either a modest or no effect of antibiotic treatment on prolonging gestation in asymptomatic women who have screened positive for bacterial vaginosis, ureaplasma, urolithecum, or GBS. If they are symptomatic, probably it is better we treat them. Although these studies are undoubtedly confounded by recolonization or reinfection after therapy and intercurrent use of non-protocol antibiotics. So it is somewhere little bit of gray area. What about trichomonas? Screening and treatment of asymptomatic trichomonas infection in HIV negative women is not recommended during pregnancy because there is no convincing evidence that it reduces the risk of preterm birth. If she has got frank discharge, if she is probably HIV positive, then we may have to treat it, do the cultures and treat it. What about chlamydia, gonorrhea, and syphilis? There is no evidence that treatment of chlamydia, gonorrhea, or syphilis prolongs gestation. Of course, you have to treat them for other reasons. The only control trial that evaluated the effect of treatment of chlamydia on gestational duration did not show reduction in the preterm birth. But we have to treat them to prevent other complications in the mother and the fetus. Right? So that's what the last sentence says. What about malaria? In malaria rampant areas, we know that it is definitely associated with preterm birth, low birth weight, and other maternal and neonatal morbidities. So prevention of malaria infection and treatment of established malaria infection can reduce the risk of preterm birth. Coming to finally my wife's department, that is periodontal disease. Although treatment of periodontal disease contributes to oral health, there is no strong evidence that treatment of periodontal disease improves pregnancy outcome because we know the association, we have not found the causal and effect. So thank you very much. I hope I have summarized this as infection being one of the important causes of preterm labor. There are many other causes, but infection, you have to actively look for, hunt for, and treat it.